Good morning. I'm Marcia Davis. I am Dean of the College of Public Health at the University of Georgia. And it is with humility and gratitude that I welcome you to the 10th State of the Public Health Conference. In these last few weeks preparing for the conference, I've been reflecting on the past 10 years and however we measure time by watching our children grow up or our vision getting worse, gray hairs coming, looking at the past 10 years in public health with Ebola, climate change, police violence, health disparities, and now COVID-19. We've experienced a lot of life. We've had our public health victories and setbacks, but through it all, we are still here, resolute in our vision for a healthier Georgia. And that's what we are here today to do, to celebrate our resiliency, our dedication, and this conference, which our goal today is the same as it was 10 years ago, to have a forum for nurturing statewide multi-sector efforts to transform the health of our communities. More than dealing with the challenges of the day or problems of the past, today we're focused on paving the path for Georgia's future. We are so glad you are here today for a grounded, practical dialogue about public health in Georgia. There are many people to thank for us being here after 10 years. I want to particularly thank Benny LaFranza from the National Network of Public Health Institutes, the staff and faculty here at UGA, and most of all, those of you who have stuck with us, whether this is your first conference or you've been here for all 10 years. It's because of you that we are here. And I'm so very grateful for your loyalty and commitment. Now let me turn it over to Assistant Dean for Outreach, Engagement, and Equity at the College of Public Health, Grace Bagwell-Adams, who will introduce us to the day.
Good morning, everyone. Thank you so much, Dean Davis, for those welcoming remarks. And I just want to also echo the same sentiment of gratitude and welcome for all of you. I know that you are giving up your morning, and we are so grateful for your time, and which is, of course, your greatest treasure. I want to also thank Dean Davis for her mentorship and trust in working on the State of the Public Health Conference. And over the last year, as we have worked to put this on virtually twice now, I have learned more than ever why it is so important to convene together and to just take a moment to appreciate one another and to really celebrate the work of public health in the state. I would like to now move into going over the agenda for the morning very quickly. On the live stream site, if you scroll down, you can see the agenda there. And I'm going to do a quick overview now. We're going to open in just a few moments with a very special guest from the Wellbeing Trust. Dr. Benjamin Miller is here with his morning keynote. We will then go into breakout sessions on minority health, rural health, and public health law. When we come back together into the general plenary, we will then have a very special spoken word presentation from Lemuel LaRoche. And finally, a closing reflection from Yvette Daniels from our own Georgia Department of Public Health. We will conclude the morning with thoughts from Dean Marcia Davis. So that is our agenda. On the side of the screen, you will see there that we do have a chat window. And you can, as you sign in, just register there, and that will be open to you. Without further ado, I would like to now move into introducing our very special morning keynote, Dr. Benjamin Miller, who is the president of the Wellbeing Trust. He is a nationally recognized mental health expert that has presented around the world on the need to make mental health an integral part of healthcare, most recently testifying before the Senate Committee on Finance about the need for an integrated approach to treating mental health and addiction. He's also the author of a weekly newsletter, Mental, Fighting the Fragmentation of Mental Health Care One Policy at a Time, where hundreds of subscribers gather to read about how everyday happenings are connected to mental health and what actions they can take to address them. In receiving his doctorate in clinical psychology from Spalding University in Louisville, Kentucky, completing his predoctoral internship at the University of Colorado Health Sciences Center, and working as a postdoctoral fellow in primary care psychology at the University of Massachusetts Medical School in the Department of Family Medicine and Community Health, Dr. Miller gained firsthand insight into our country's foster care, education, healthcare, and criminal justice systems. He saw how the continued marginalization of mental health in America has ripple effects throughout every layer of society. Dr. Miller has received numerous awards for all of his work, which includes leading the Agency for Healthcare Research and Quality's Academy for Integrating Behavioral and Primary Care Project, the Sustaining Healthcare Access Across Integrated Primary Care Effort SHAPE Project, and acting as a technical expert for multiple CMS panel discussions. He has also written and published extensively on enhancing the evidentiary support for integrated models, increasing the training and education of behavioral health providers in medical settings, and the need to address specific health policy and payment barriers for successful integration. He was the lead author on the Robert Wood Johnson Foundation Culture of Whole Health Report, which provided specific direction to advance mental health nationally, and is on the editorial board for Family Systems and Health. His work has taken him into communities all across the country, from the Rocky Mountains in Colorado to the foothills of the Appalachian Mountains in Chattanooga, Tennessee, where he currently plays music, paints, and spends time with his wife and daughters. Dr. Miller, it is our great honor to have you here with us this morning. We have so much gratitude for you, and we really look forward to your remarks. Thank you so much.
Thank you for that wonderful introduction, Grace. It is an honor to be with you here today, albeit virtually in Georgia. I'm so close yet so far. I want to thank Dean Davis and Vinny for the opportunity to really join you all and discuss one of the most important topics that I can imagine, mental health. So today is all about mental health. What a time to talk about mental health. You know, like many of you, I've really been feeling what it's like to live in such uncertain times, to have my kids at school and then all of a sudden back at home, then at school again. To feel like we're coming out of a pandemic only to fall headfirst back into it. It's stressful and it's quite scary. To be afraid for my parents as they reach their older years, to be afraid for my loved ones, to work too many hours at this desk that you're seeing me sit at right now because it's easier to not leave here than it is my desk in my office. There's so much weighing on us, from fires to politics to a raging virus. This is a moment for all just to take a collective breath and reflect on what we've learned and where we should go from here. I recall early in the pandemic, people describing that they wanted it to go back to the way that it was before. Well, I hope that you hear from my comments today, the way that was before wasn't working for a lot of people. And as it relates to mental health, the topic that I'm going to cover in great deal today, it definitely wasn't working. So that brings me to today, my talk and our time together. So I want to do three things with my talk. First, I want to lay the context. I want to explain where we've been, where we are, and where we could go. Second, I want to offer up ideas on solutions from the most obvious to maybe some not so obvious and innovative. And then finally, I wanted to challenge us. I really wanted us to think big for Georgia. What's possible for public health? What's possible for the future for mental health? And I'm going to do this all in 30 minutes, so hang on tight. Okay, so take just a second to think about your mental health. If we were in a room, this would be a lot easier, but I'm just going to ask you to reflect on this. How's it going? Think about your kids, think about your family. How are they doing? Chances are, at some point during the last 2 years, the answer to that was probably not great. You have the stories, I have the stories. There has been a lot of pain, a lot of suffering. I've had one too many calls to learn the loss of a loved one. I've seen the eyes of a mom who's lost their son to suicide, the father who lost his daughter. And I'm not really even talking that much about COVID yet. From suicide to drug overdose deaths, the loss of life has been very real and very much in all our faces. And remember, COVID hit us when we were already struggling. As a nation, we roughly lose about one person every 3.5 minutes to a preventable cause. Over 156,000 lives were lost before COVID in 2019 from drug, alcohol, and suicide. Kids are suffering. Hospitals are declaring mental health crises. We've each felt mental health in more profound ways now than ever before. So we knew there were problems with mental health before COVID. In this moment, This moment, my friends, gives us the time to act. But in order to act, we need to know what to do. What solutions for mental health can best meet us in this moment? So I believe this is a convergence of crisis and opportunity. And I hate to be just so tongue-in-cheek here, but Homer Simpson taught me a word during the pandemic, and it was crisitunity. And if you think about crisis and opportunity, the merger there is an opportunity for us to really begin to consider ways to advance mental health. So in this darkness, we can find hope. The silver linings that can keep us going, the stories that make us believe things will get better, and those are out there. They're powerful and they're worthy of discussion, and I'm going to come back to those in just a second. So Wellbeing Trust, in partnership with Trust for America's Health, has been putting out annual reports that we call Pain in the Nation. They analyze data from the CDC on mortality with a specific eye on what some in the literature call deaths of despair. If you're unfamiliar with the term, I already mentioned it. This is coming from economists Ann Case and Angus Deaton, who were recognized for really discovering these disturbing trends in 2008, deaths to drug, alcohol, and suicide. And if you look at the data during the 2010s, over 1 million Americans died from these issues. This past decade saw persistent increases in alcohol and suicide deaths and exponential waves of overdose deaths from different types of drugs. And in the recent batch of data, which I know many of you have seen, these trends continue, including increases in alcohol-induced and drug-induced death rates, skyrocketing death rates from specific type of drugs, and worsening trends among certain demographic and geographic populations. There were also some trends that we saw in 2019, which I think highlighted our country's increasing problem with disparities. For example, we saw the age-adjusted drug-induced death rate among Blacks surpass whites after many years of having substantially lower rates. But let me focus in on drug overdose rates just for a second. Drug-induced death rates increased by 5% in 2019 from 2018, which was driven in large part by increases in synthetic opioids and psychostimulants. And the available data indicates that 2022 could be worse. And what we've seen from the provisional data, it is much worse. The most recent data shows another massive spike. The 12-month data that was released from the CDC ending in February 2021 showed almost 97,000 lives lost, which is about 7,000 more than the previous 12 months. So people have been calling out for help for a long time. Yet treatment and mental health and addiction services have not yet met the demand and frankly aren't meeting people where they are. I mean, look at the data. In reality, about 1 in 10 people with an identified substance use disorder receive recommended treatment, or less than 50% of those that have a mental illness. And according to our partners at the Kaiser Family Foundation, roughly around 40% of Americans have delayed accessing healthcare, which includes mental health, because of concerns about cost. And 4 in 10 adults who have insurance say they still have trouble affording their deductible. But these stats are well known in the health space, and you can't be a wonk like me and not have them just frankly memorized. I'm sure you do too. But when we look at the social space, it's just as bad. When we compare the US to other countries, nearly half, or about 45% of the US adults who experience emotional distress also report being concerned about neighborhood safety or having enough money for basic necessities like housing and food. When you compare that to only 16 to 19% of adults reporting emotional distress in the UK, France, Germany, you can see it's pretty clear that the unmet social needs in the US may be more prevalent than in other high-income countries, which potentially contributes to the experience of emotional distress. And then add back into this equation the challenge of getting access to care when you need it, the inability for many people to have health insurance, and you've got a pretty significant problem. And then COVID hit. And so in a survey that we did with Viacom, CVS, and the Benenson Strategy Group, we basically looked at a sample of adults and asked questions specific to the coronavirus and mental health. And we learned a lot from these data, including several trends that emerged that provided support for the need to prioritize mental health. And actually, one of the things that was most interesting is that most people said that lawmakers should be prioritizing our mental health more during coronavirus. And so we found that in a matter of weeks, alarming 55% of adults interviewed said that COVID had affected their mental health. It's hard to imagine any scenario dealing with something as unknown as COVID and not be a bit stressed for sure. However, at this moment, the multitude of stressors may be like pouring gasoline on top of an existing wildfire, and it's burned. So colleagues and I continue to try and call attention to the issues of mental health early on in the pandemic. I mean, this is from April in USA Today. We published an op-ed calling out these problems. I pointed out, as I've done even this morning, that life expectancy in the United States has already been on the decline, in part driven by unaddressed issues that were in some part social, some part economic, and many parts mental health. So my charge was that I wanted the public to see how these issues were impacting all generations, what it was doing to our kids, ethnic and minority groups, and though at differing degrees of severity, and how in the best of times our country still had not resolved itself that mental health and addiction was a big enough priority. So now in the face of a global crisis, we're at a critical pivot point for mental health in our country. And I feel that this is the moment for policymakers to rise to the challenge. So I look back at the op-eds, the TV appearances, all of this stuff. I see us pleading for people to pay attention to mental health. We knew the data and we knew that it was possibly coming our way. I have to say, it's kind of funny to look at these pictures now because most people grew a pandemic beard. I shaved mine, so went the opposite direction. And we know the impact trauma can have on our health. This is one of the issues that I know many of you in public health get, but this is a ripple effect. This is a pretty big rock that we just threw into the pond. Trauma's impact can be direct and indirect, as we know from the literature, and as so much research has shown, that trauma can negatively impact our health and well-being. Case in point, natural disasters. That's an easy one to look at. Hurricanes, earthquakes, fires, and even man-made disasters like mass violence. They're consistently associated with increases in the rates of PTSD, depression, anxiety, substance use, youth behavior problems, and more. And we all know the literature on trauma in childhood and its lasting effects on health and well-being across the lifespan, including higher risk of a wide range of chronic disease as kids become adults. And we look at a study that came out about a month ago, roughly 40,000 kids had lost a loved one during COVID. And I'm sure that number has greatly increased over the last several weeks. In 2020, the COVID-19 pandemic created new, almost inconceivable heights of trauma, grief, stress, and isolation for many Americans. The harm from COVID extended morbidity and recoveries, and the deaths reverberate past survivors and the deceased to families, friends, caretakers, and colleagues. We're all living with this. And it shows. The CDC reported early on in the pandemic increases in overdose deaths, anxiety and depression, and calls to the crisis hotlines. But honestly, I don't know if any of us should be surprised because we took away all the tools that we had to manage our stress, each other. We took away our routines, those things that really gave us some sense of normalcy. And we asked an unsuspecting public to manage things that they weren't already great at managing before. Survey after survey after survey after survey pointed to something building. We weren't sleeping. We were eating too much. Our worry was impacting our bodies. But interestingly, we sought care. At least many of us did. Loosening the restrictions on telehealth definitely helped. And we could use any device that we wanted for the first time to talk to our clinician. We could connect to a professional in ways that we hadn't been able to before. But still, more people needed care that could not get care, as seen in these data. And I think a major lesson to be learned here, which I'll reflect on in just a minute, is that we learned that people really like it when you make care easier to access and when care comes to them. And we're still in this pandemic. So what can we do? What options can we pursue? Well, my friends, like many states, Georgia faces no shortages of challenge related to mental health. I give you the numbers you've got to memorize. Nearly 1 in 5 adults in Georgia battles mental illness in a given year. That's about 1.4 million Georgian adults who have some form of mental illness. Roughly 500,000 people have had a major depressive episode last year. Nearly 2,000 Georgians died of drug overdose-related deaths in 2020. And as the CDC reports, the number of overdose deaths in Georgia rose at least 38% during the pandemic. Well, herein lies the challenge that I present to you today. A challenge that I hope you accept, because within this challenge is an opportunity to radically rethink how we approach mental health, to go deep on reform and consider new ways we can begin to approach a problem that has been a problem for far too long. But I want to recognize that each of us inherited processes and structures and systems that might not be the right processes, structures, and systems to allow us to be successful. I believe that our house is built on sinking sand. Our structures that we've inherited, they're deeply flawed. There are assumptions about our system, our models that need to be examined closely. Let me just point out a few for mental health. The mom who presents to a pediatric practice with the son who's acting out and then told to wait 6 weeks to see someone who specializes in helping. The student who's engaging in self-harm confides in a teacher and has the police show up as the first response. The inmate who's decarcerated only find out that there is no health insurance to allow them to continue on their medication that had made them stable while they were in prison. And I could go on. We all have these stories, and at their core, they force us to re-examine our structures and ask, what is working here? Let's definitely keep some of the good things. I'm all about that. But let's eradicate ourselves of the faulty policy and programs that have stymied us for decades. Assessing our structures requires us to take a step back and to look at how we administrate, finance, deliver, and support mental health. It's a hard but worthy task, and I actually think this is something that all states should do. So I want to offer 3 challenges for Georgia, and I want to dive deep on ways that we can consider new opportunities for change around mental health. These are bold ideas that will take us from relatively easy, to pretty hard. But my intent here is to challenge you and to see the interconnectivity between these 3 challenges and how they can complement each other if done right. So number 1, let me ask you a question. What happens when we don't have a vision for where we want to go? What happens if we don't have a vision for excellence? What happens if we don't have a roadmap, love that term, for change? These questions I've grappled with for years and have seen one too many states not be able to answer the most basic questions of what's our vision for mental health. I can tell you stories and stories of sitting in rooms with folks that are responsible at a state level of managing mental health and asking this question. And depending on where they sat within what agency, what funding mechanisms they might have at their disposal, what measures they used, what constituents they were responsible to, they never really got the same vision totally on the same page. So I think that lands us in a place that we circle around status quo and we never really make progress. And sometimes this means that we focus on a policy that's not in service to a different direction, or a program or a funding mechanism that just simply reinforces the same. I think the science is clear though, and you as public health professionals know this better than anybody, but when healthy community conditions, good coverage, inclusive policies are in place, we can achieve positive outcomes that improve the mental health and well-being of all Americans. But to accomplish this goal, it requires a comprehensive framework that sees mental health as existing on a continuum that begins in community and extends into places like healthcare. If we're serious about tackling mental health and addiction in our country, we must leverage all the places that people present with needs and provide support accordingly. That's the premise of what you see here in front of you. Bring mental health to where people are, from schools to prisons to primary care. We perpetuate a fragmented view of health when we ask people to wait, ask them to follow up on a referral that's weeks out. That is not working for people, and it wouldn't work for you. Just think about your own life. So Georgia, like many states, has begun a journey to integrate care. You've pursued some policies, some thoughtful programs, you've got wonderful leadership. However, if you're looking for a place to start, I believe there's no better place than trying to focus in on primary care, the largest platform of healthcare delivery. More mental health is seen in primary care still in any other setting. Well, prisons might be a close tie now, but primary care still remains the delivery setting where we see most of our mental health and addiction needs. This initial framework that you see here in front of you is what we thought excellence could look like. And it tried to articulate to best address mental health. We have to go deeper in community. We have to address things like poverty, housing, transportation, which I think are preconditions for good mental health and well-being. Of course, we've got to get coverage too, and then we move to care, looking to integrate mental health to wherever people are. And as I mentioned about primary care, and the Commonwealth Fund, as you can see here on the slide, has pointed out, many other countries have done a much better job at basic aspects of integration. Using primary care as the example here, my academic life was spent studying how to integrate care, how to integrate mental health in primary care. I can tell you the ins and outs. I have published more papers than I care to count on this issue, and probably that only my mom has read, but if you're interested, I can share them with you. I think that the challenge here is that we're really facing a paradigm that supports fragmentation. When you bring mental health, primary care together, it does change the paradigm. It creates a new structure for people to access care. In fact, Wellbeing Trust has even partnered with people like the Bipartisan Policy Center to release a set of bipartisan federal policy recommendations on this topic. I won't go into too much detail on this here, other than to say, if part of Georgia's vision was to do more integration, especially in that context of primary care, here's a good place to start for your relatively new elected senators. But as I mentioned, a vision needs to create a system of care where mental health is everywhere. we worked to create what you see here in front of you through a guide that we call Healing the Nation, which is a policy platform that was built off the framework that I just showed you that offered programmatic and policy recommendations for federal policymakers in each of these broad categories. And I would go so far as to argue that without bringing mental health into these places, we're really going to miss an opportunity to meet people who have the most need. We took the federal program and we created state-specific version. This one was done with the United States of Care. It was our attempt to bring the framework and the vision of excellence to a place where states could enact change. They could see a place that they could take action. But the bottom line for this number one challenge is that without a vision, many of our policies, our programs, and our investments fall short of moving the needle. They're educated guesses that keep us disjointed and at times working against each other, which is not an ideal. Which brings me to number two, opportunity and challenge. So some context here. And I feel bad in saying this because I've hit workforce pretty hard, but I'm going to hit it even harder now. 33% of individuals who seek care wait more than a week to access mental health clinician. And that's a pretty good number. You can look all the way up to 6 months in some counties in the United States. 50% of folks drive more than 1 hour round trip to see a mental health clinician. We actually published a paper years ago that looked at the importance of proximity to mental health clinicians and showed, the further you were away from a clinician, the wider the disparity gaps were. Probably not a surprise, but no one had published on it. Plus, I love geocoding and mapping things. So it's perhaps no surprise to you. Adding insult to injury, 50% of US counties still, to this day, have no psychiatrist. And while those statistics are indeed daunting, they focus only on identifying a clinician. Once you get into care, it's a whole other set of barriers you have to face. For example, mental health office visits with a therapist are 5 times as likely to be out of network compared to non-mental health office visits. These barriers are more significant in communities of color, particularly the Black community, and often results in more severe mental health concerns due to unmet need. Again, furthering our disparities. But rarely is the workforce in the places that we need them. So take a minute and just ask yourself again, what would you do to address the workforce problem in Georgia? How would you solve this ridiculous maldistribution problem that we have on having a lot of our clinicians work only in urban areas? How would you address the disparities that are so egregious in certain communities where there is literally no one? For me, these data have caused me to rethink the problem and the solution. Our workforce is in serious need of redesign. It begins with these 4 questions you see here on the slide. What's happening, where, to who, and how? I think these questions are actually a wonderful filter of sorts for any of our workforce efforts. And here's the kicker here. Central to any meaningful redesign in healthcare, any policy discussion is inevitably our workforce. We have to have it. Who is doing what, where, to whom, and at what cost? I mean, those are the basic policy questions. Most policy solutions, though, tend to focus on the supply of the workforce. How many clinicians do we have? Where are they located? And I think that if you look deeply into that question, the answers to that often leave you pretty dissatisfied because the answers are we want more, and we usually want more in the places that they're not. That doesn't seem to be a tenable, viable solution here. Recently, a colleague and I, Dr. Anita Burgos, published a paper looking at providing a framework for the mental health and addiction workforce in the United States. This is built off the framework that the WHA published all the way back in 2009. And it really proposed 3 shifts that need to take place at the clinical, community, and individual level to adopt this framework and to achieve this broader goal of population health. So the paper focused on laying out the proposed framework, and then it offered specific policy considerations that can help us better reconceptualize who the workforce is and enhance our overall capacity for our clinics and our communities. And I believe this paper has been a driving force in offering clarity in my thinking. Simply put, we may be asking the wrong questions about workforce. Instead, we may need to begin to think about a new strategy for addressing community need, a new workforce that emerges in community, by community, and for community. So on this graphic, I want to call out 2 things specifically. So the bottom 2 categories. You've got community health workers and peer support specialists. Those are critical. And I believe that in the last 10 plus years, we've really embraced this concept of having the extension of CHWs, peer support specialists, promotores, really help augment a lot of the clinical delivery, and in many cases do it much more effectively. But it's this last category, community-initiated care, that I want to focus on. Because to me, this is the opportunity that Georgia has that is radical. It's an opportunity that almost anybody has that hasn't been pursued. Countries all over the globe have trained lay people in interventions that work, but the United States has not adopted this. So what does that mean for us? Well, it begins with this. When you're in crisis, who's the first person you call? Imagine that person being able to actually help. They have the skills necessary to intervene. They could give you more of an intervention, less so just empathy, which is great. Empathy is wonderful. But the sad truth is most of us don't possess those interventional skills. We get worried, we get afraid, we say call 911 or go to the emergency department. And that doesn't work for a lot of people. They delay care, things get worse. Or in the worst scenarios, they might take their own life. So what happens when you train non-clinicians to do tasks clinicians do? So let me tell you a quick story. And many of you are probably familiar with this literature, but I actually think it's a wonderful story that exemplifies this. Dr. Dixon Chibata, who's a psychiatrist in Zimbabwe, he often talks about losing this patient that he had to suicide. And in his discussions, he recognized that he could not be everywhere at once. And he'd want to develop some type of model that would allow for him to train people who were actually there to do something. So he started with grandmothers, who were the matriarchs of the village. And he spent years developing an evidence-based intervention and to study what happened. And he published an RCT that was in JAMA. And he found that when participants were taught a structured approach to identifying mental health problems and workable solutions, outcomes got better. These were lay people. These were people trained with new skills. They didn't go to graduate school. Some of them didn't even go to what I guess you could call high school. Yet the model has not been scaled in the US despite having such robust evidence. And that's just one study. There have been meta-analysis published on task shifting, task sharing, systematic reviews. The literature's there. So what does this mean for Georgia? What does this mean for us and today? I actually think it means a few things. Maybe we need to think differently about workforce. Maybe our clinical role is less important than maybe we thought. It's still important, but maybe it's less important. Maybe there's a major place for us to help empower communities and train them up at a broad scale to start to tackle some of these issues in their own way, using low-level evidence-based interventions. I will never forget at the beginning of the pandemic, writing letters to the White House, to the administration, talking about the importance of contact tracers. And I know many of you were right there too. On the front lines, contact tracers were, in many cases, the people that were recognizing that there was a problem. What happens if we had trained up our contact tracers to do some work around mental health? And this brings me to my last challenge to you, number 3. We've never really created a system that we need for mental health. And we need all of us to make noise to get to that system, to advocate for change. However, what happens when we don't have enough voices talking about it? What happens if enough of us aren't out there screaming for reform? Sometimes we end up preaching to the choir. And I think for public policy, this has got to change. So we need a social movement for mental health. And to do that, we need to apply social movement principles on our work. These have been written about extensively. And if you read enough about them, there's really 3 main ingredients that stand out there on this slide. Vision and framing. You could think of this as hearts and minds. You got to appeal to people's hearts and minds. We've hit on this a bit already today, but my friends have taught me the importance of this. They've actually worked in the marriage equality space, and they can tell you that if you only looked at the policies, marriage equality would have never happened. But when you made it about love and connection, you saw a change. 2, a constituency. You have to have people, starting with friends, family, and community members. Eventually, a successful social movement means that clinicians and leaders at all levels of society are on board with your vision. And 3, a long-term commitment. You got to know that social movements, they're not episodic. They're all about long-term perspective and investing in building relationships and training those future leaders who can keep the work going. There's this brilliant author that I'm just infatuated with, Jane McElvey, who writes about the difference between organizing and mobilizing. And she posits that a lot of organizations that think they are organizing are just, in fact, mobilizing. And the biggest difference here is that organizing are knocking on the doors of the people who don't know that mental health is their issue. Mobilizing are getting the people that already know it's their issue and getting them to do something. We mobilize really well. We don't organize really well. Most mental health advocacy organizations know how to mobilize. But for the broader initiative that we're going to have to pursue, we've got to get out there and knock on different doors. So here's my take. We need to bring more people under our tent to make mental health everyone's issue, not just some issue. And in doing so, we will have a new constituency, one that can not only be equipped with new skills, but can lead a revolution for mental health. So now it's back to you. Our future. The COVID-19 pandemic that has enveloped the world has created these additional stressors that I've described to an already devastating situation. And as I've outlined here, emerging data indicates that Americans really are struggling with much higher rates of distress, substance use, drug overdose over the past year. Without urgent action, these issues, which are already on a grim trajectory, may continue to heighten in the coming years. So this is on us. This is on our watch. What will we do? Well, we all need support coping with and healing from the pandemic's harm. Our communities also need help managing this emerging crisis. Mental health conditions and substance use disorders, we need to pay attention to early intervention, improve medical care and treatment, and harm reduction policies. And we need to better address underlying social and economic conditions that will support and ultimately bolster our health. To accomplish this, though, we need that vision that I mentioned. A new workforce, a constituency to push for change. We need all of you, of course, and we need you in the places that people are, but we also need you to lead, to help prepare our communities to manage some of these issues themselves. The difference you will make can be multiplied by helping train up our communities in mental health interventions and skills. It works, but at its core, it's a fundamentally disruptive idea to move care away from caregivers and clinics to enable a new workforce that emerges in community. So in closing, here are my 3 takeaways and my challenge with you for the rest of your time today. Number 1, create that vision for mental health, please. One that reunites the triplets that my mentor always taught me that were separated at birth: public health, mental health, and primary care. Consider carefully our structures and how they reinforce a fragmented approach to those 3 issues and make accessing care more challenging. Write it down, work towards it, look at policies that can support it. Number 2, as we think about and rethink our structures, let's consider our workforce. Let's break down the traditional walls of care and better democratize knowledge so that all communities have the ability to better intervene on mental health and addiction. And finally, number 3, let's build that constituency, one that didn't know that mental health or public health was their issue, and get them to see it for what it is, the foundation to their health. So I want to thank you for the chance to share a few words this morning. Thank you for the amazing work that each of you do daily to advance the health and well-being of those in Georgia. It matters. It really does. Now is our time to be bold, though, to not embrace timidity, but to be bold, to see the suffering that's happening all around us and to rise to meet the moment. If anyone was well equipped to lead this charge, it is you. People who truly understand the role of prevention, social factors, and innovative ways to let the community lead in solving complex problems like mental health. Thank you for your time today.
We're so glad to have you here. As Dean Davis opened this morning and said that today is a celebration, I think it's more than appropriate for us to come together and to have a few moments with dear friend and colleague, Lemuel LaRoche, who's going to be sharing some of his art and work with us. I think that central to health and well-being is connection to one another. That's been a theme this morning. And central to connection is really just sharing art, and life's art is poetry. And so we are so grateful to have him here. I'm going to read a little bit from his bio on his website, which I think is so beautiful, and then turn it over to him to share with us. For Lemuel LaRoche, there's only one path. He believes that we can rebuild ourselves and our communities. The strength to do so, he says, is already inside us. Empowerment from within is the core principle of LaRoche's community work and therapy. In 20 years of professional experience as a community organizer, educator, public speaker, and adolescent counselor, Life challenges the people he works with to discover that they already possess the tools required to improve themselves and their neighborhoods. Life helps youth learn positive behaviors by playing chess. He teaches teens and young adults to work through the problems they will face in life with reason instead of reaction. A chess player must plan and envision possible outcomes, move quickly without thinking, or losing is inevitable. Using chess as an empowerment tool began when LaRoche counseled youth cycling through the juvenile correction system. Think before you move. Learn a way of thinking that creates progress, not retreat, and not surrender. Seeing the potential chess unlocked in youth, he decided to bring the strategic games lessons to a broader audience, and so he founded the nonprofit Chess and Community that brings together young people to compete and learn leadership skills. The Athens-Clarke County government selected LaRoche to co-facilitate a youth task force that aims to address deficiencies and outcomes for young people growing up in Athens. He's also returned to the University of Georgia, where he earned a master's in social work and teaches graduate level courses that prepare future social workers to recognize bias and succeed across differences with open hearts and open minds. In response to his many forward-thinking efforts in Athens, Life has received the Fulfilling the Dream Award given by the University of Georgia President Jerry Moorhead to deserving Athenians who live out the dream of Dr. Martin Luther King. He's also known as Life the Griot, an accomplished poet. He is the author of 2 books, Hidden Ripples, Life's Unspoken Language, and Tree of Life, The Human Ascension. He continues to write and perform regularly. All the work LaRoche accomplishes today is the product of a lifetime of inspiration and an education that placed equal emphasis on good words and good works. The path LaRoche chose in life is not an easy one, but he asks only not to walk it alone. Together with friendship and kindness and honesty, he believes we can empower each other to build the communities of our dreams. Without further ado, I'm going to turn it over to you, Life, and I thank you for joining us this morning.
Thank you so much. I just want to take, give me a second. I just want to take a moment to ask all of us to take a moment and let's do it like a collective breathing, right? We just got to take a moment to just be present and just breathe in this moment, right? Right. We are all trying to hold the line, and especially the line of our sanity, right? Where systems around us are changing. We seem to be at the midst of a social collapse, and we're seeing it in our communities. We're seeing an uptick in community violence. And as public health, we need to start looking at violence as a public health issue rather than an isolated situation. So I always try to ask myself that I am not the puzzle. I'm a small piece of it. And in recognizing that I'm a small piece of the puzzle, I try to do my part. And in doing my part, I know that Grace is doing her part. I know that everybody else is doing their part, and collectively we can at least try to hold the line and try to maintain. But the most important thing is, as you all know, is that self-care. You know, taking a moment to really care. You can't pour from an empty cup, and if your candle ain't lit, there's no way you can put somebody else's fire on if you ain't got none on your own candle, right? So taking that moment to self-care, taking that moment to really take care of yourself. So this poem I'm about to do, this is actually one of my signature poems, and it's designed to challenge us to start thinking about systems differently, but most important, what part do you play within that system? I'm going to paint a broad picture, and within that picture, you're going to find your place, your space in it, right? And I'm challenging you, it's called a project, so I'm challenging you to say, what is your project? How are you managing this project and your project, and what are you willing to do to change what we see happening today, right? So to open it up, when I was 13, my father walked me through the streets of Brooklyn, New York. And he would always encourage me, look, you either going to be part of the problem or you're going to be part of the solution. 13, I don't want to hear all that. I just want to go to Coney Islands and enjoy myself. So no, we're going to walk. And we walked from project to project. And he allowed me to see that this is all part of a structure, a blueprint of self-destruction. Now, what role do you play in that, right? So since then, I've become a young man. I've traveled throughout the country. I've traveled through different parts of the world, and I've seen the same blueprint everywhere I went. So this is a challenge more than a poem, right? So little Abe salutes his comrade and takes a bullet for his project. The kid who squeezed the trigger, he pulled it for his project. Now it's war between the kids and the projects. The city confiscate the land, and corporations bid for the project. They start laying pipelines from the prison to the project. Flooded with drugs, drain the vision out the projects. Put cameras on the posts, wired fence around the projects. But still I seen an empty weed bag laid beneath the bench of the project. On top, these kids sit, they're getting high in the projects. Though the sets up, bandanas fly in the projects. Bullets were exchanged and mothers cry in the project. She said her son was born in a project. He died in a project. They call it social engineering in the project. Grandma got slapped by her grandson, but no one caring in the project. We take from each other. No more sharing in the projects. These words cry for change, but no one hearing in the projects. Instead, we hear these broke rappers throw knots to make it rain in the projects. And coppers told Glocks left his black boys slain in the projects, where trappers sell rocks, crack grain in the projects. This leaves little Abel as unable. It's too much Cain in the projects. Too many grown men mimic Lil Wayne in the projects. Too many flowers shaking their stems for fame in the project. Pedophiles walk with no shame in the project. Dogs roam these streets unchained in the project. Rip roses from the earth. Young boys are running trains in the project. And worse, ministers who claim to be ordained in the project, using the Lord's name in vain in the project, hustle God with snake tongues and leave spiritual stains in the project. Come on, 4 churches on 1 block, still nothing gained in the project. But liquor stores, where they drown out their pain in the project. Crack house, where they empty out their veins in the project. Slow genocide, slow genocide, slow genocide to nothing remain in the project. It's bioengineering in the project. Biological warfare is the project. Syphilis in Tuskegee was a project. Bombs dropped on Move in Philly was a project. Chemtrail clouds over our city is a project. Radiation in the soil is a project. Fill the oceans with oil was a project. Genetic modifying foods is a project. Use frequencies to control our moods is a project. COINTELPRO was a project. The CIA flood our hood with blow, it was a project. So crack in the hood was a project. Birth of a nation, even the clans and white hoods was a project. The prison complex is a project. The housing complex we call the projects. Now we call all of our housing complex the projects, but it's a new day. Let old scars peel from the projects. We want change. We gotta want to deal with our projects. Correct those that rob, rape, and steal in our projects, and those that hustle white death to kill a zeal in our projects. My father said, young boy, your hand is a deadly weapon, but could also be used to heal our projects. Plant good seeds, watch the harvest yield in the projects. Learn to utilize the parks and the fields in our projects. Take back control, we gotta wield our project. Turn every man into an armor and a shield for the project. Is warfare, become a righteous seal for the project. Aim high, push the moral will of the project. If humanity is beautiful, then let it be revealed in this project. Let's start by giving back the lies and focus on what's real in our projects, like grow food so we provide the meal for the project. Eat healthy to eradicate the ills in our projects. Natural herbs in place of dietary pills in our projects. Try 3 days a week without salt as your project. Bring your sugar intake to a halt as a project. Fast 2 weeks off Facebook as a project, and put you and your child's face inside a book as a project. Let's teach our sons chess and karate in the projects. Let's teach our daughters self-esteem, self-love, and Pilates in the projects. Take the television off, read more in the project. Open up your eyes, see more than a project. Open up your mind, see more than a project. Don't settle for a cell, be more than a project. Don't settle for your cells, be more than a project. Don't settle for a gel, be more than a project. Now we know the problems. What's the solution? Collectively, we have the solutions, but it's going to take for us to really work together, and it's going to take for us to get serious about what we're seeing in our communities. And it's a lot of confusion from the top, but how do we not echo the confusion, but really begin to work on the ground to make a difference, right? So thank you all so much. Become a part of the solution, not the problem, as my father would say. Thank you so much for having me here, Grace, and you all please enjoy the rest of the conference.
Thank you, Life. I'm going to end the way that life began, I think, which is always an important thing to remember, and that's just to take a breath. So if we could just all take a collective breath together, let it out, and just want to say thank you again, Life, for sharing your work, your art, and your wisdom. We're going to segue now into our closing reflection from our next honorable guest, and that is Yvette Daniels. And Yvette, I'm going to introduce you and read your bio and then turn it over to you. Yvette Daniels currently serves as the Director of University Relations for the Georgia Department of Public Health, with responsibility for establishing effective college and university relationships through the promotion of public health programs at the state and local level. She's doing a beautiful job of that today as she comes with us to celebrate the 10th anniversary of the State of the Public's Health as our closing reflection speaker. And I'll share a little bit about her background as well. Previously, she served as the Director of Health Promotion for the Georgia Department of Public Health, where she was responsible for 4 programs that included maternal and child health, women, infants, and children, health promotion and disease prevention, volunteer healthcare program, Office of Health Equity. Before joining DPH, Ms. Daniels was an assistant state attorney, the state attorney's office in Jacksonville, Florida. As an assistant state attorney, Ms. Daniels was assigned to the sexual assault unit with responsibility for prosecuting sex offenses against children and women. She earned her bachelor's degree in political science from the University of Georgia and her Juris Doctorate from the University of Georgia School of Law. She also currently serves as the president of the University of Georgia's Alumni Association. Yvette, we're so grateful to have you here and to hear your reflections on public health and the State of the Public's Health Conference. Thank you for joining us.
Thank you, Grace, for that kind introduction. And I'm so happy to be here with all of you today. I'd first like to say to Dean Davis and to all of those at the College of Public Health, congratulations on the 10th anniversary of the State of the Public Health Conference. This signature event is more important than ever. You never fail to disappoint in bringing public health professionals, students, leaders together to really address the most pressing issue of our time. And today is no different. And all that we've heard today from our speakers touches right on what we do, what we're dealing with right now, which is so important. I'm also very thankful to the University of Georgia and the College of Public Health for ensuring that even in a pandemic, we can still spend this time together and talk about these pressing issues in spite of what the current world looks like. I'm honored to be with you all today and give reflections on the power of partnership and engagement in addressing public health challenges. And first, I'll say that this conference is actually that. This conference is one place of many across the state where we can begin that process of creating partnerships and engagement. It is an opportunity for us all to be together. And I actually had my aha moment, my light bulb moment in 2015 at the State of Public Health Conference. For the first time, I was a presenter of a poster with a student who was a fellow in our agency for that semester. That fellow is now a public health employee and has been for some time. And I realized then that there was a great impact that we could have across the state if we worked together more and we did more together, sharing our insights, including students and professionals together. And I think my reflections will share some of that. Back in 2015, I became the Director of University Relations, and I really did spend quite a bit of time getting to know our academic partners. What's happening on these campuses? How can we bring practice together with academia? Because I think for a long time, while the two existed, we didn't always play together very much. But what I found out is that there was already some interaction and engagement happening. And what I tried to do, and I hope what we've seen and what many public health professionals did, was to try to elevate that work and really do more to engage together and not separately. When I think about what I've seen, it really does fall into 3 buckets where I think our work has been impactful. Working with academic partners, presenting more, speaking more, internships. And in those buckets, I think what we've seen is a great willingness of public health professionals to share their work with schools and colleges to assist in bringing academia and practice together and bringing practice to students across the state. I think we also saw what I've seen over the last 5 to 10 years is an increase in our partnerships with the medical community. I always tell people public health is everything in the alphabet. We're A to Z, we're AIDS to Zika. If it's a part of public health, we're in it. We're dealing with it, we're addressing it. And so it's really important that we engage all public health professionals and all medical professionals, whether it be doctors, nurses, pharmacists. All of that is public health. And so we saw many more partnerships, rotations. We're seeing more and more doctors in our medical schools wanting to bring medical professionals into the public health practice space to see what we're doing, to see how we do it, to learn from it, because what they'll learn from that work is how to do their jobs even better. And I think we're seeing that, and we've seen that. We've also seen a lot more work dealing with our schools and colleges and their partnerships. We've been lucky enough to engage over the years with programs at UGA and at the Rollins School of Public Health with their international partnerships. So we've increased our partnerships, not just statewide, but globally. And I think that comes from us engaging and spending time together, academia and practice, not separate, but together, because they learn from us and we learn from them. And so I'm thankful for us and having those relationships with our academic partners, that they were willing to come to us and say, we would love to see our Humphrey Fellows from the Rollins School of Public Health come to the Department of Public Health to understand the work and how you all operate at a state and local level. And then they're taking that information back to their communities. The same thing with the College of Public Health, bringing the CDC Pudong delegation from China to Georgia to get a firsthand view of what we do here and what it looks like to work at public health at the state and the local level. And from that, we learn and they learn. And we take back ideas to our respective areas to become better at serving people and increasing the population that we serve and how we can serve differently. There's always learning and growth in that. I think the thing that we probably know the most about partnerships is the pandemic. And I think all the work we've done over the last 10 years really came to light this year, this last 18 months. When we made the call to our academic partners that we needed help from students across the state to serve and work as contact tracers, case investigators, everyone was there, ready. What do you need? How can we help? What can we do? And that came from trust and relationships built over the years. To me, that is the product, that end product is making that call and everyone saying, tell us what you need. We'll get to the students. How many do you need? We'll send them to you. And they did. And actually, for our state, students were the first wave of students were the first wave of workers addressing the pandemic. Over 400 students have been hired over the last 18 months to assist. And it's been the best practice any student could ever get in their public health career as a starting point. They got to see public health practice up close and personal. And I think many of them, it only energized the fire in their belly to work in public health. For some, I think they realized, wow, I like this part, I don't like that part, which is actually okay. What is what we want to see? We want to see students make a good decision because they've had lots of experiences, and we've been lucky that we've been able to share that opportunity. And for students to now see that maybe they do really want to be in public health. And I'll share with you that everyone that came to work for us did not have a public health background. We saw students in social work. We saw students who were actually getting medical degrees. We saw students in communication. So once again, public health is everything. It's AIDS to Zika. It's almost any career that you might do in your lifetime has some tie back to public health. And those students got to see firsthand how they could work in public health. And many, I think, will go on in their careers down a public health path based on that experience. The other thing we saw a lot more of is now students seek us out. We've been going to internships, intern career fairs for years, but now we don't even have to go sometimes. They're tracking us down because they're seeing the work that we're doing firsthand. They're going to conferences like this. They're seeing for themselves the work that can be done. And they're using that and coming to us to get those jobs and to look for those opportunities. We also saw an increase in participation in students at our conferences. So the State of the Public Health Conference is one area, but there are others. I would be remiss if I didn't talk about the partnerships that have come from working with the Georgia Public Health Association and including students there, engaging, allowing them to present, to work with and see what's happening on the practice side. APHA, which many students will probably get to present at some point in their career. All of that is because we've been building relationships with our academic partners and with our schools and colleges across the state to do more to help engage and share all the good work we're doing and how they can be involved in it. So I'll say this, where public health practice and academia meet, ultimately, it's all about students for me. And how do we help the next generation of workers, public health workers specifically, see how they can fit and bring their gifts and their skills and their insight into the world of public health locally and at the state level. We see that every day in our work, and we know how important it is for them to be a part of that. They're the next generation. And who knew that a pandemic would bring the world to a standstill, but provide so many opportunities to share what we do on the larger scale with the world and with students who now get to see what it's like to be in public health. We would be crazy not to continue to engage in that. This is, I think, just the beginning of what good relationships can look like. And there are opportunities that we can continue to do even in this pandemic. And I'll say what I also learned in that pivot from live to virtual is now we can do anything with students. They can intern, they can shadow, they can have coffee with a professional on Zoom. And I encourage you, if you're encountering students in your world, to do that. They want to hear from you. They want to learn from you because they want to be where you are one day. And the only way they'll get to see that is if they interact with us on a regular basis. So I'll leave you with a few closing thoughts. Some things I think we all can do to continue with building partnerships that actually make change is to be open to being really uncomfortable. Because where you're uncomfortable is where you're going to have the most growth. And all of us have felt uncomfortable at some point in our careers. And so I encourage everyone on this conference today to get comfortable with it. Because when you open that door of discomfort, you're going to find a lot more growth for you and the person that you're working with. I say that to students all the time to encourage them. So I want to say that to you. As the world returns to whatever normal looks like, discomfort will come. And I know that if we are open to it, we can grow from it and we can leverage it to work, to learn, to encourage others, and to be part of a bigger mission, which is really to protect all Georgians. And in order to do that, for us to do that, we will need to get uncomfortable even more. I'll also say to you, and I've heard this throughout the conference today, be kind, be helpful. We know everyone is going through something now more than ever, and they may not always tell you what it is, but it exists, acknowledge it, and sometimes let it roll off your back and accept it as that. And finally, I would say to all of you, be hopeful. Based on my personal experience for the last 18 months specifically, what I have seen talking with students, talking with public health professionals, talking with our partners, everyone wants to do what's good and right for this state and this community and for public health overall. And I really think there's great hope for all of us in the future. I think the students are the main crux of that. And I'm hopeful because I believe we are in great hands, good hands going forward. And that's where my hope lies. I hope each of you will remain hopeful as well. And I thank you for the opportunity to share some reflections over the last 10 years. Thank you.
Thank you so much, Yvette. We're so grateful to have you here with us today. We're grateful for your partnership. And I just think as we approach the end of this virtual conference today, that's going to be the takeaway word for me, and I hope for many of you, is gratitude. Thank you so much. And last but not least, we are about to have some concluding remarks from our wonderful Dean Marcia Davis. And again, I want to thank you, Dean Davis, for having the vision 10 years ago now that this event was needed. And I think it plays a critical role in giving all of us a moment to pause, to, as life has advised us, to breathe, to think about some of the most critical pressing issues that are facing us as a state and as a sector. And I think also just to come together with one another and to share a moment as public health. So thank you again, Dean Davis, and we look forward to your closing remarks.
Thank you, Grace. Thank you, everyone, for your participation in the conference. As I was taking notes today, it seemed like I've come up with a lot of C words here. But now is the time for us to be courageous, compassionate, to have a clarity of vision, to engage our community, and to have conversations. So I hope you've been inspired today. I hope we have given you some words of wisdom, some words of inspiration, some words of hope that we can again carry on and meet each other again, hopefully in person for our 11th conference of the State of the Public Health. So thank you all. And we will be in touch throughout the year with exciting plans for webinars and continuing education across the state. So again, thank you for being here. And good luck, Godspeed, stay safe, stay healthy, and we will see you in a year, if not before. Thank you all.